Right, excellent. Right. So now we come to the more clinical part of the talks, I think, with starting with respiratory medicine. And so asthma would be the main focus of this talk because biologics have been big in asthma. So my summary of the talk would be, again, quickly run through the basic. I thought I was coming third. That's why I just quickly skimmed through the basic, which we have done: asthma, lung cancer, and interstitial lung disease. I know lung cancer is more for oncology, but just to give you a perspective about lung cancer, what medications have been used, and because those patients, same patients can, if they are receiving immunotherapy, can come to you with autoimmune disease, and you have to know certain aspects of those drugs that have been used so that you could know the possible adverse effects of those drugs. So again, I told you about the immune system: antibodies, white cells, complement, autoimmunity, allergy, and then allergy is where respiratory medicine, asthma, etc. comes in. So that is the component, and then Kamal and Arjuna will be talking about the autoimmune conditions after that. And the thing is to bring that back to baseline and to take specific pathways rather than just using steroids ad hoc and just affecting every component of the immune system and just blunderbuss approach of using big dose of steroids. We want to be a bit more selective in the correct, appropriate group of patients. This is not in every patient that walks into your outpatient room, in the correct group of patients. So if we look at, I told you the different types of cells. We are talking about the Th2 cell here, the one that produces IL-4, IL-13, and IL-4, IL-5, and IL-13. That is the important bit of cytokines when it comes to asthma and how we try to take it off. When it comes to cancer, we are talking about the CTLA4 and the PD-1, PD-L1 pathway. Because in cancer, the lymphocytes go, but there is a shield between the cancer and the lymphocyte. We want to remove the shield. We want to remove the break, and that is immunotherapy. Because if you find colorectal cancer, breast cancer, etc., or colorectal cancer, lung cancer, the important aspect today, you find the lymphocytes going into the area, but they can't attack the tumor. That is what they have to do. They have to attack the tumor because there is a shield, and that shield is removed in immunotherapy, which I will talk in a bit later. So let's go to asthma and focus on asthma and how it's where does biologics fit in the basic management in the management of asthma. This is the GINA 2020 guidelines. All of you would be very, very familiar with this sort of guideline, step 1 to step 5, and we are concentrating on the step 5 category, the severe patients who are ending up in ITU, who are ending up in hospital, who are taking a lot of healthcare resources. But that's the group that we want to target with these different medications, not the standard asthmatic who gets a bit of wheeze once or twice a month, etc. So the important group of patients who are on oral steroids or high dose inhaled steroids with a LABA. So that is the group in which the step 5, especially the step 5, is the one that has to be assessed and phenotyped properly and endotyped if possible, so that they are the appropriate biologics. It is targeted at that group. So if you look at this pathway, you have 2 different types of asthma. You have the allergic asthma, the non-allergic type, and you can see here, this is quite a complex schematic. But basically, if I want to point out a few things, you have the eosinophil. Eosinophil is a very, very important cell, excellent for parasitic infection, has a lot of toxic chemicals. It doesn't have to go to the airway and release it because it can cause bronchial hyperreactivity, etc. So this, and then what is one that stimulates the eosinophil? It's a chemical called IL-5 produced by the Th2 cell. Then you have IL-4 and IL-13 are the 2 important cytokines, which are important for producing IgE, which goes and binds to the mast cells. Again, so those are the the important cells when it comes to the allergic response. You have the non-allergic response, the neutrophilic response, which you phenotype and endotype them, and then that is to other cells in the immune system. So if I focus some aspects here, it's IL-5, IL-4, IL-13, and some other chemical at the top of the slide, just below the airway epithelium, that is TSLP, which is the one that is produced another chemical that is produced to initiate this whole process into the whole process. So if we look at this, you can see that you have a normal airway, you have eosinophilic asthma, you have non-allergic eosinophilic inflammation, you have non-eosinophilic asthma. So a whole range of things. Basically, what a respiratory physician or immunologist, allergist who sees this patient would try to do in this group of patients using different biomarkers, etc., to try and put them into different categories, skin test, eosinophil count, etc. This is exactly what we do. And so basically, if you put a sort of snapshot of management of asthma, this is one slide that you just sort of take with the GINA guidelines, mass target treatment. Most patients receive ICS, sub-alarm, the whole range, the leukotriene receptor, antibody hormones, etc. So that is how we treat asthma, basically, a big rump of patient, nothing major, just, you target it, ensure that they take medicines and that they will get proper adequate control of that. Then you stratify them, TH2, TH1, using biomarkers, and this is where you do personal asthma treatment to the group that is more severe. And then you have the different drugs, IgE drugs, anti-IL-5 drugs, together with the other agents, and these are the predictive biomarkers of response. So we use the few of these to be able to predict whether what patient should receive what drug and whether they are showing effective response. So if another schematic that shows the same process is, there are 5 classes of drugs that I want to talk to you. The IgE drugs, which are shown here, the IL-5 drugs, which are shown here, the anti-IL-5 drugs. Then I won't talk too much about the anti-IL-13 because they were not the best drugs around. Then I'll talk about the IL-4, IL-13 drugs, the combined receptor blocking drug, and these are what I will talk in the next few slides. So what are the asthma drugs, biologics that we have? 5, I put 6 here, but 5 are the main things that we approve. And omalizumab, mepolizumab, resiliency benralizumab, and dupilumab. These are drugs which are used. We use it on the different groups of patients based on the need, and there's different pathways. So again, remember, asthma, this is on a select group of patients who are going into GINA 5, etc., that will use this group of drugs. Quickly run through the thing. Omalizumab has been there for ages. It has been approved. It is approved up to 6 years of age. Used quite a lot of it. We use it in urticaria. I've used it a lot in urticaria from my practice, a lot in urticaria, chronic spontaneous urticaria, which is not responding to standard treatment. Even in Sri Lanka, we have used that drug here, approved quite a long time. And there are certain, these were the first, so what does it do? It binds to the free IgE and it downregulates the receptor of the IgE receptor on the surface of mast cell. It's it binds to a site that doesn't cause cross-linking. And this has been there for ages. And we have a number of other second level anti-IgE medicines. IgE binds to mast cells, so that's an important medication when it comes to managing severe asthma, rather than keeping them on high dose of steroids for ages and getting all the complications with regards to steroids, high dose of steroids. So we have different sort of tables that we use in asthma with weight and the IgE level, but in urticaria we don't use this. We treat them without using this table, but in asthma you do use this table, the weight and the total IgE level, and it can be used up to 6 years of age. So next we come on to the anti-IgE, then we come to the IL-5 drugs, the eosinophil, the one that causes the eosinophil to come to the site, and the one that causes the eosinophil to remain, to not die, but to remain long-term at the different site. Initial data showed that it was not beneficial, but in recent years we have found that mepolizumab, resiliency and benralizumab have been quite effective. This is one of the studies which are important, published in the New England Journal, which showed that basically sorry, it is I'm sorry about that. This is the omalizumab study which I'm speaking, and this was the study that showed that omalizumab was effective across a range of, and this was an important New England Journal study, coming to the IL-5 drug. you find that IL-5 drugs are inhibiting both the IL-5, which is found important by eosinophil survival and eosinophil coming to the site, and the IL-5 receptor, which is found on the surface of the eosinophil. So those are the two drugs, those are two areas that the drugs will try to target and get rid of. So what are the drugs? Mepolizumab. Mepolizumab, again, approved in 2015. You give it 100 milligrams subcutaneous 4 weekly, very first-line drug in this group of patients, especially eosinophilic asthma, severe eosinophilic asthma patient. This was the study, the New England Journal study again, which first opened up this field, the study, which showed that it was beneficial, but a small group of patients. This was followed up by the DREAM study, which is a bigger group of patients, published again by the Leicester Group. And what they basically showed that there was a big difference between those receiving mepolizumab as opposed to those receiving placebo. So that was an important thing across 3 different doses. Next, we come on to, and then it reduced asthma exacerbation, and it also reduced the glucocorticoid sparing effects. In 2014, 2 back-to-back papers came which showed that it reduced the amount of glucocorticoids, oral glucocorticoid, that are needed in this patient, the Bell paper and the Ortega paper, which showed that mepolizumab was effective in treating severe eosinophilic asthma, both asthma exacerbation and to reduce the amount of steroids they're taking. So then we come on to Resiliency Map. Again, the difference, again, an anti-IL-5 drug, but the difference was that this drug had to be given IV, and that's an important thing, while the other drug can be given subcutaneously at home. By this Resiliency Map, it has to be given IV, but it is important in certain groups of patients that we use, which I won't go into detail. The IL-5 receptor drug is benralizumab. Sirocco trial came out with this, showing the benefit of this study. And this is a great medication because we can use it 8 weekly, initially 4 weekly, but then we go on to 8 weekly, and we don't have to get the patient getting the drug too often. So that is the IL-5 receptor. The previous 2 drugs were IL-5 itself. And this again showed, the NIAS study showed that it has a glucocorticoid sparing effect in patients with severe asthma receiving this drug. So I've spoken to you about the IL-5, I've spoken to you about IgE, and the last 2 aspects I'll talk to you about is the IL-4, IL-13 receptor, which is an important drug to inhibit the effects of IL-4 and IL-13, and that is a drug called dupilumab, which you use a lot in atopic dermatitis, and also in asthma. It has been approved for asthma. So this dupilumab is a monoclonal antibody which inhibits both the IL-4 receptor and the IL-13 receptor, and therefore the signaling of that receptor through that receptor is reduced. And this was the first study, the Salivancel study, which showed that it was very beneficial. It was beneficial in patients with increased eosinophil counts, and this was followed up by the Castro study, which showed that it was important and safe in patients in moderate to severe uncontrolled asthma. So we have another class of drug, again, FDA approved for severe asthma, not managed by the standard medication needing oral corticosteroids or high dose inhaled corticosteroid. So those are the 5 class of drugs that I would want you all to take home from this place. This is the RAB study, which again showed similar data, back-to-back studies in the New England Journal. So the 5 class of drugs are omalizumab, mepolizumab, resiliency-map, benralizumab, dupilumab. I told you about TSLP. It's higher up. It's produced by the epithelial cells of the airway, and that can be inhibited. And there's a drug that is in the development and would be used. That is tezolizumab, and that was acting on this higher component for TSLP that is produced by the epithelial cells. The studies that have been published with regards to that comes next. And this was again a New England Journal study which showed that this was beneficial in a group of patients who have severe asthma. So what I've done was gone through the different pathways, gone through the different medication that can be used in these different pathways. And these are the sort of schematics that we use in deciding whether the person should have omalizumab, how do you evaluate it, whether they should have one of the IL-5 drugs, whether they should have whether they should have dupilumab. And like rheumatology, like IBD, in asthma, you have different pathways in making these decisions. So if we go quickly, next 3 minutes on lung cancer and interstitial lung disease, just a few slides just to put you all into perspective, because this was on respiratory disease rather than asthma that I was only talking about. So lung cancer, the standard method, surgery, chemotherapy, radiotherapy, you know, we have targeted therapy and immunotherapy come into focus, and this is where the world is going with regards to treating cancer at the present moment, using the other three methods as sort of a foundation. So depending on the genetic mutations, lots of genetics are being done very early in cancer care. Depending on the gene mutation or the fusion or the exon changes, you can go for targeted therapy or for immunotherapy based on that. The EGFR pathway is important. You study these pathways, you can intervene at different levels using different inhibitors. And this is just a busy slide, but just to show you the different drugs that have come in, including immunotherapy, into the management of lung cancer. And that is a big area of sort of research and clinical medicine, because lung cancer is a difficult cancer to treat with the sort of baseline methods, and you do need targeted therapy or immunotherapy. These are the sort of targeted therapy drugs that have been used based on the pathway that is affected, and cancer immunotherapy consists of the different immune checkpoint inhibitors that have been used, and you will see increase in C patients because some of them get autoimmune disease. So this is the immune checkpoint inhibitor, the PD-1, PD-L1 blockers. So finally, I want to end up with telling you that even in interstitial lung disease, you have certain medication that have been, so interstitial lung disease, finally, both in sarcoidosis and other interstitial lung disease, you have a whole range of biologics that are being tested at the present moment. It integrates with the rheumatologists, etc., because of the common disease pathways, but I won't go into detail, but just to tell you that the number of biologics working on, including the anti-TNF drugs, which will go in importantly with the other two conditions. And this was a quick run through, basically, of the basics: asthma, 5 drugs, IgE, anti-IL-5, and the IL-4, IL-13 receptor, and TSLP, lung cancer, targeted therapy, immunotherapy, and interstitial lung disease, which are coming to focus with regards to TNF and the rituximab and the other drugs. Thank you.